And now the last thing that we have to know is when should keratoplasty be done, and Dr. Jadeja will tell us.
A relevant course on a very happening subject. Queries based, so the last query, as we said, is when keratoplasty is to be done. Keratoconus by itself, the progressive thinning and bulging induces the distortion in the cornea, leading to the blur, as can be seen here, with no proper focusing and cannot be fully corrected by any optical correction. In advanced cases, there is a loss of vision, and majority of these might end up having surgeries, and we would want to define when would the surgeries be applicable. But there is no precise definition to say absolute cutoff for those advanced cases, despite all the indices, metrics, the AIOC2022 and topography features which will help you in sort of grading them, because there's a very poor correlation between this indices and the actual clinical effect of that distortion. A very mild case might still have a lot of distortion, whereas a very advanced case might still be correctable with the other means. So when surgery, when the high irregular astigmatism or the scarring primarily because of the disease process or secondary to eye drops leads to a functional loss of vision, where the correction is inadequate or not tolerable in terms of the lenses that we talked about, and the visual excess is not spared. So if the visual excess is obscured like that, or there is a very advanced thinning with improbable fitting of a good correction, that's when, and when the other means of halting the disease progression have exhausted, or the patient primarily presents where these means are no longer applicable, or there are complications from the earlier discussed means. So all this, the final go would be correction with keratoplasty, or if there is a corneal infection due to the contact lens wear, and that is now rendered with an opacity. There are charts, flow charts for those of us who prefer to have a discretion over like when to actually step into this. With all this cross-linking, the trans-PRK with cross-linking, the ring segments and combinations of all this, finally, when none of this is like applicable is when you are going for transplants. Transplants by choice for those conservative people who don't choose to go beyond the safe limits of the earlier discussed modalities. That's when you don't want to actually risk the probable ill effects to the stem cells or the recently discussed sudden absorption of the corneal stromas, which have been being discussed on the cornea groups, where you find this cornea to have reduced to 150 or 200 microns post some years of cross-linking. Surgery, classically, a penetrating keratoplasty has excellent outcomes visually, optically, where we have a full thickness disc which is placed there and secured in place with sutures. Yet, over the years, DALK has become the chosen or the golden standard for this type of conditions, advanced keratoconus, where you dissect as deep as possible, leaving the healthy endothelium in place, and place the donor button shelled off of the endothelium and suture it in place. Now, both these techniques have sutures in place, yet DALK does not have an open sky. It's in stronger eye in the long term. Little work is done in the anterior chamber. No risk of endothelial rejection, which decreases the need of further replacements. There is less requirement for steroids, less risk of secondary glaucoma, and this can be further fine-tuned with the use of femtolaser if available. Now, this is subject to endothelial health and scarring. If these two were present, then you are not having a chance of doing a DALK, though in some cases of scarring, you might still be able to manage to a DALK. The procedure for DALK would be either a manual dissection or the big bubble technique, and the big bubble technique can be type 1 or type 2 with reference to the Duval's layer, where the dissection will be in front of it or in. But then there's more to this when about surgery. Classically, this is what we would talk in terms of the optical things. But then if you look at these eyes, which are often having the vernal keratoconjunctivitis or the allergic conjunctivitis factors, or in dry eye, or blepharitis associate, or there is hyperactivity of the meibomian glands due to rosacea or acne in these patients who are young ones. So look for this. If there is farinaceous keratopathy like this, with this sticking of the mucus strands and all this, you need to work on this. Look at the lids. If they were like this, you can't do surgery at that stage. You need to treat this with the appropriate treatment with the different combinations available for these dry eyes or allergies or the blepharitis. Otherwise, you might end up with having sutures which collect mucus like that, or they collect sterile collections around them. These are not infections, these are mucus collections which are around and there are cellular reactions along with mucus collections, and they tend to loosen up the sutures earlier. So you will end up with having this irregular area, which is again not desirable because we are working to decrease those irregularities on the surface. When you remove them, the curvature might settle, but you'll have this ugly scars. These are young patients, you don't want them to be cosmetically disfigured like this. And further on, you might have filament collections here where the patient will remain symptomatic for a longer time. So to get out of this, you want to first take care of the surface disease, but you also want to make sure that you have a very good edge-to-edge match while you're passing the sutures. But host rims tend to be thinner here, and that's where if you match them like this, you'll have surface problems, but you'll want to match them Bowman's to Bowman's, in which case you'll end up having regular contours. This is the left side of the graft and this is the right side of the graft, where you end up getting very good contours with small bulges between the sutures which settle out after the removal of the sutures. Talking about the scars where you can still manage to do a DALK, this was a case where we had some scar in the periphery and a DALK was done, sparing the pupillary area, and there is this deep scar which can still be managed with a DALK. Just 2 minutes. This was one with high drops, and this DALK was managed with a manual dissection, and after the surgery we can see the two edges of this thing, but with still a clear area in the donor graft. This is a localized separation in the descemetes with donor graft, which resolved over the period of time. However, this right part was good enough, and it was the pupillary area which didn't have this separation, so the ultimate outcome was reasonably good. Distortion can be a torque sort of distortion can be there, giving this sort of stria in the periphery, which if not in the pupillary area are still acceptable and does not hamper the visual outcome. Last but not the least, this is because of the bandage contact lens which was used and a pseudomonas infection. So all our patients will always want to be wary of not having this, and a cautious note should be used for this. Add-on surgeries might be required later on for this grafts for more fine-tuning of the optical corrections. So transplant, finally in the summary, is not to be done as long as the myopia and astigmatism are correctable to acceptable levels, optical aids are well tolerated or can be made tolerable by the other means in combinations. Cornea has a clear visual axis, there's no scarring and edema in the relevant area. Progression is under check with the help of the earlier discussed means, and there's a monitored compliance for keeping the allergy quiet. Finally, it has to be a good functional vision, which is good enough for day-to-day work for that individual. Thank you for your patient hearing, and thank you, Dr. Rajesh, for